So we just have a few short slides about fructose metabolism. So fructose is a major dietary component in sucrose, found in fruit, as a free sugar in honey and in high fructose corn syrup. It's taken up by the cells through facilitated diffusion using the GLUT5 transporter. Fructose is principally metabolized in the liver, and the initial step involves phosphorylation at the 1 position to fructose 1-phosphate. Fructokinase is the major enzyme involved, and this enzyme has a high Vmax and rapidly phosphorylates fructose as it enters into the cell. From here, aldolase B cleaves fructose into dihydroxyacetone phosphate and glyceraldehyde. Both of these products can then enter through the glycolytic pathway as glyceraldehyde 3-phosphate. What's important to note here is that aldolase B is the rate-limiting step for fructose metabolism, but it's not the rate-limiting step for glucose metabolism. Aldolase B has a much lower affinity for fructose 1-phosphate than it does for fructose 1,6-bisphosphate, which we know is part of our regular glucose metabolism. As a consequence, after ingesting a high dose of fructose, normal individuals will accumulate fructose 1-phosphate while it's slowly converted to the glycolytic intermediates. So there are 2 deficiencies in fructose metabolism to be aware of. The first is essential fructosuria, and that's caused by a deficiency in fructokinase. A deficiency in fructokinase is a benign genetic disorder. In this case, an individual will have fructosuria, which simply put is fructose in the urine. As fructose in this case is not phosphorylated and trapped in the cell, therefore any ingested fructose is shed in the urine. In contrast, hereditary fructose intolerance is caused by a deficiency in aldolase B. This results in the accumulation of fructose 1-phosphate and can cause clinically relevant symptoms, most notably hepatomegaly or an enlarged liver and fasting hypoglycemia. The accumulation of this intermediate eventually inhibits both the processes of glycogenolysis and gluconeogenesis due to the lack of free phosphate. Let's compare those deficiencies here. So again, in essential fructosuria, our deficient enzyme is fructokinase. Loss of fructokinase has no clinical consequences, as in this case, fructose is not phosphorylated and it's not trapped in the cell. This is in contrast to hereditary fructose intolerance. This is due to a lack of aldolase B. Aldolase B, again, is our rate-limiting step for fructose 1-phosphate metabolism. In this case, we have an increase in fructose 1-phosphate in the liver. That accumulation of fructose 1-phosphate can result in fasting hypoglycemia due to a lack of free phosphate. The lack of free phosphate impairs fasting metabolism. If we remember, our fasted metabolic pathways require phosphorylation of the regulatory enzymes for activity. And if we have reduced levels of free phosphate, that impairs our ability to generate ATP in the electron transport chain. So let's finish with this clinically relevant question. We have a 2-week-old infant brought to the emergency room due to lack of energy, diarrhea, vomiting, jaundice, and an enlarged liver. The physician prescribes a switch from breast milk to a formula containing sucrose. This switch results in a resolution of the baby's symptoms. And now we're being asked, which of the following is the most likely diagnosis? So before we get to our answer choices, let's look at a few key pieces in the question. The first is, what is sucrose? And sucrose, we know, is made of glucose and fructose. And breast milk, on the other hand, is primarily composed of lactose, which is glucose and galactose. So now let's look at our answer choices. First, a deficiency of an enzyme in the metabolism of pentose sugars. Pentose sugars, or 5-carbon sugars, are used in nucleotide synthesis. They're not primarily oxidized for energy, so it's unlikely that this would be the root cause of our symptoms. Second, a deficiency of an enzyme in the pathway that primarily metabolizes glucose. This is also rather unlikely, as we have glucose administered in our infant formula and we're able to resolve symptoms. Next, an intolerance to dietary galactose. If we note the change in diet from breast milk to formula containing sucrose, the shift here is the alleviation of galactose from the diet. So this is a likely answer. But let's look at choice D first. Choice D, an intolerance to dietary fructose. This is not the case. You can see here that in their new diet, fructose and glucose are both present and we're able to alleviate symptoms. So it looks like C is our best choice here. And that is our correct answer. Intolerance of dietary galactose by this infant is likely the cause of our symptoms. When we remove galactose from the diet and replace that with formula containing both glucose and fructose, we're able to alleviate the symptoms. See? As easy as that.